first of all, also, you should look at the list for American Heart Association and TCT, but I think it's pretty impressive if you look for Mike. Mike has 7 or 8 original abstracts on that he's on at American Heart Association, which I think is pretty amazing, and Barb, same thing along with him. So look at them carefully, because I think you'll be really impressed with the quality of original research. The next person is actually Mike Miedema, and Mike is presenting some, I think, really important data, again, from the level 1. We'll be doing his master's in clinical research
public health, yeah.
in public health next year at Harvard, and then will be joining us. Is that official? Not quite official.
It is now, I guess.
But anyway, we're hoping that he'll be joining us, and so Mike is also presenting, I think, some really important data.
Yeah, so Tim and I have been working on some data. I'm interested in preventative cardiovascular medicine. And so we looked at the medications that people are on when they come in with their STEMI, not what they leave on. We all know that they leave on the right medications. The question is, what are the medications they're on beforehand? How is their preventive therapy prior to their event? And we presented the initial data last year at HA, and so now we're kind of doing a follow-up abstract to that, looking at the incidence of premature disease and female gender in the STEMI population. It's a pretty straightforward poster and just has a couple of take-home points. I kind of expanded the introduction and the discussion to focus on a couple of themes in preventive cardiovascular medicine that I think are really important, that are gaining a lot of evidence right now. So when we think about cardiovascular prevention, there's really 3 main strategies. And the evidence for secondary prevention is pretty clear. We kind of know what to do with those people. The evidence for primary prevention is a little bit more ambiguous, and we aren't quite sure what the proper approach is at this point. And this is the majority of our population, so this has a lot of impact. Current guidelines are basically to only treat the high-risk patients. We take people with overt hyperlipidemia, or if you have multiple risk factors and qualify as high risk by Framingham, those are the people that get treated. And there's mounting evidence that that might not be the best way to do things. Polyfill is obviously one approach that's being studied that might work, but implementing it is going to be a whole different issue. And then further risk assessment is probably where most of the evidence is building, where we want to better define people's absolute cardiovascular risk and then target those who are truly high risk for disease. And currently, as I was saying, we reserve statin therapy and aspirin for people that have hyperlipidemia, and we base it largely on LDL. And that has a number of issues. LDL is not an incredibly potent risk factor. It's a risk factor for cardiovascular disease, but it's not a very strong one. And so this has gotten into a little bit of trouble. The evidence that absolute cardiovascular risk is the way to go continues to mount in that if you have a high enough absolute cardiovascular risk, it doesn't matter where it comes from. It doesn't matter if it's from high blood pressure or high cholesterol or genetics. You benefit from the statin the same, regardless of what your cholesterol is. And so this is kind of the classic slide from the Mr. Fit trial. And the black bars here are the distribution of lipids in the population. This is well over 100,000 patients. And the line here is cardiovascular death. And so if you look, it's skewed a little bit this way. So total cholesterol is a risk factor, but there are a lot of people with kind of borderline elevated and normal cholesterol that are dying of cardiovascular death. So basing our medical therapy just on cholesterol is going to get us in trouble, because no matter where we set the bar here and determine that these people are high risk, the majority of the events are going to come from people that are therefore not high risk. This is the classic prevention paradox. We kind of proved in our data last year that we presented that of the people with a STEMI coming in, only 24% are on an aspirin, 16% are on a statin, and about 7% are on an aspirin and a statin. So we're not treating the vast majority of people that are having events. And these are all people without known coronary disease prior to their event. So these are all people that would be treated under primary prevention prior to their event. And so really the other data that's coming out is that there are 2 groups especially that are undertreated, women and young males, people with premature disease. So if you're a female and you're 70 years old or younger and you don't have diabetes, 92% of those people are low risk by Framingham. And so if you're low risk by Framingham, you're not supposed to be treated, and you're not supposed to get further screening. You're not supposed to get a calcium score because you're low risk. And that would be fine, but we know that a lot of events come from this population. So that there are a lot of people that are having events and that they could have saw the doctor the day before their STEMI, and the doctor would say, don't worry, you're fine, you don't need any treatment. And then for premature people with disease, even if you have multiple risk factors, by Framingham risk, you're often not high risk. Most of the time you're not, in fact. You're often in that intermediate risk category. And family history isn't part of the Framingham risk score, so they don't really get factored in as well. And this is Roger Blumenthal at Hopkins has a big research group, and they've done a ton of this preventative research. And just focus on this bar right here. These are people that have had calcium scores and had their risk assessed. And this is men, and the black bar is women. And if you're a female and you have a calcium score greater than 75th percentile, so this is a high-risk group. These are people that have events. 83% of them don't qualify for medical therapy in the absence of the calcium score. So we're not going to treat the majority of women. And the same goes for younger patients. These are all people with premature disease, or all people that are less than 55 for male, less than 65 for female. And for those, again, with the calcium score greater than 75th percentile, 80% of them pretty much wouldn't be treated by current guidelines. So if women and young males represent a substantial portion of our STEMI population, preventing further STEMI through primary prevention is going to be difficult. And also we were going to look at the question of whether or not they might be on lower rates of medications in general compared to the population, which is already has low rates of use. So we took the MHI Level 1 program. We took all the demographics of consecutive STEMI patients. And back in 2007 is when they started recording the pre-admission medications. We have data over the past 3.5 years. We just analyzed the use of preventative medications by these different demographics. And this is an important slide. So of the 1,707 patients that we analyzed, 1,180 didn't have known disease prior to their event. So that's 70% of the population. So 70% of our STEMI population that comes in had no idea they had coronary disease prior to their event. So the vast majority of our STEMI population is treated under primary prevention prior to their event. Of that 1,180, 483 had premature disease. So just over 40% are actually younger than 55 or younger than 65 for male and female. And if you look at the non-premature patients, 195 of those are females. So that gives us a total of 57% of our patient population is either premature disease or female. So the majority of our, close to the majority of our population is coming from two groups that we don't treat very aggressively at all when it comes to primary prevention. And if you look at their demographics split up by the prematures and the non-prematures, it's a little bit interesting. The premature people are more likely to be female, they weigh a little bit more, and 85% of them are current or former smokers. So a little bit different risk distribution than the non-premature people. And a little bit lower incidence of hypertension, same incidence of hyperlipidemia, which is important, and same incidence of diabetes as well, and obviously more family history compared to those people who are non-prematures. So this is all of the primary prevention people. So this is all the people without known disease. This is basically the data from last year, where most people aren't on appropriate medical therapy. When we split it up by age, if you're a premature person, you're even less likely to be on medical therapy. So about half the rate of aspirin use, only 15%, and only 5.6% of people are on an aspirin and statin in the primary prevention group if they have premature disease. So very, very low rates of medical use. And if we split it up by male-female, there aren't differences between the two, but we have to keep in mind that the females are 10 years older, and they have more hypertension, and they have a trend towards more hyperlipidemia as well. So despite the presence of more risk factors, they still aren't on any more medical therapy. If we look at the people with known disease, so this would be the people treated under secondary prevention, I think it's still important to look at. We know that all these people should be on these medications. Only 70% are on an aspirin, 60% are on a statin, and if we look at all four of the the evidence-based medications for people with coronary disease, only 22% are on all four of those when they come into the door. Now, this is obviously a very pre-selected population because these are people having recurrent events. So these are people most likely to keep smoking, most likely to not take their meds. So it's you have to analyze this with a grain of salt. If we split it up by male and female, everything is pretty much equal except for aspirin therapy, which is interesting. And there's actually a couple other studies that have shown that females are less likely to adhere to aspirin long term. There seems to be an increased risk of GI side effects. And this, even after we can correct for age and hypertension and the other risk factors, this still holds true that females are less likely to be on aspirin in the secondary prevention group. So women and young males do represent a substantial portion of our STEMI population. Use of preventive medications in this group is incredibly low, even compared to the baseline group, which is already low to begin with. So further reducing that rate of STEMI through primary prevention is going to be difficult unless we change the way we approach these patients. And so we need better risk stratification. And I'll close just with a couple slides from another trial that I think is very important because I think it gets at where potentially we might be headed. And so we know that we're broadening statin therapy to lower risk populations. And probably the most popular trial looking at this was the Jupiter trial, and which used Crestor in people that had an elevated CRP with one or two other risk factors. And the problem when we get into these lower risk groups is that the event rate from an absolute perspective is really, really low. So we had an almost 50% relative reduction in events, which is outstanding. But if you look at the total graph here, the absolute event rates were incredibly low. So you had an absolute reduction of less than 2%. So we're basically treating these 95% of people that are not having an event. And so from a cost standpoint, we run into problems. And if you have any amount of side effects with medication, you're going to run into problems because the majority of people you're treating aren't going to have events. So if we could take this group and better risk stratify them, that would be very, very helpful. And so there was a group, the same group at Hopkins decided to do that, and this was a really smart trial. They basically took the Jupiter criteria and they applied it to MESA. MESA is the current big population cohort that's getting a lot of research done. And so they took everybody out of that MESA cohort that would have qualified for Jupiter. So these were all patients that were eligible for Jupiter. They had risk factors and they had an elevated CRP, and they could have been in the trial. And they looked at what calcium scoring did to their risk long term. And the results were really fascinating. So out of the 1,700 people in the trial, if you had a calcium score of 0, which was half of the population, so half of the Jupiter eligible population had a calcium score of 0, for those 444 patients, they had 2 events over the next 7 years. They had an event rate of 0.8 per 1,000 patient years. So basically that correlates to a less than 1% 10-year all-cause mortality. So this is an incredibly low-risk group. If you have a calcium score of 0, even with an elevated CRP, even with other risk factors, if you don't have plaque, you're very, very unlikely to have an event. So it would be very cost-ineffective to treat this group. As opposed to if your calcium score was 100 or greater, which is 25% of the population, 75% of the events came from this group. And so their hazard ratio is 27 compared to the calcium score 0 group. Just to give you an idea, elevated cholesterol has a hazard ratio of about 1.8. Elevated CRP is 1.6. Most of our risk factors are in the 1.5 to 2.5 range. And here they got a hazard ratio of 27. So these people are markedly elevated risk, and this is where most of the events are coming from. If you had even a little bit of calcium, they had a hazard ratio of 4.91. They still were kind of in the intermediate risk group, but they still were significantly elevated compared to the 0 calcium score group. And so if they made that into a number needed to treat for just to reduce a coronary heart event versus a cardiovascular event, the people with calcium score 0, 549, which is a very unfavorable number. This would be very expensive to treat this group. Whereas if you had calcium, the number needed to treat 24, that's very cost-effective to treat that group with an aspirin statin. And so it gets back to this whole prevention paradox, which I talked about, where wherever we set this bar here, we're either going to overtreat or we're going to undertreat. Whereas if we kind of extrapolate this graph into what they got from the MESA Jupiter population, here we have 50% of the population that basically doesn't have events. This is the group where we'd want to stay away from. Whereas you have 25% of the population that has 75% of the events. This is the group that we'd want to target. This would be a very cost-effective group to target long term. And that's probably the best way to reduce events. So we aren't quite ready for screening in general for calcium scoring. We aren't recommending that for everyone. But the evidence continues to build that if you have enough risk, further risk assessment with a calcium score really does provide a lot of benefit.
A couple of quick questions while Ron gets his, let's get up. So Mike, just so everybody knows, Mike had a paper that was a highlighted paper in Circulation just a couple months ago, and this manuscript that you just saw is actually ready to resubmit within the next few weeks, right?
Yep.
The next person actually is Ron Reiter. Ron is a fellow at the University of Minnesota and with us until we split, but has done a lot of great work with Jay Travers and has actually 2 presentations. And this paper that he's just going to present now is actually in press and Circulation research. So it's really outstanding work, and I think you'll be impressed with it.
Thank you very much for giving me the opportunity to present our research here. So what we looked into is basically if time of onset of myocardial infarction influences time of onset of myocardial ischemia, I should say, influences the infarct size and the ejection fraction. First to the background, we know that circadian rhythms influence cardiovascular physiology. This is mainly heart rate, blood pressure, hormones, thrombolytic factors. I could put in here also sympathetic tone. I could put here, like multiple platelet aggregation and so on. And we know cardiovascular events also occur in a time-dependent pattern. This is like an old slide 25 years ago where we see sort of like the plotted the frequency of onset of myocardial infarction. We see a clear circadian variation here. This circadian variation mainly has been attributed to these factors here, difference in heart rate, blood pressure, hormones, sympathetic tone, and so on. And but sort of like more recently now, there has been exciting data out there that there is sort of like a molecular mechanism known as the circadian clock that's potentially also involved in this circadian variation. And we have this characterized well within the human and in the rodent heart. Just a very brief background. So circadian clock, what is that? Basically, we have a couple of like clock proteins that have over a very intricate positive and negative feedback loop, basically oscillate around the 24-hour cycle. So this is one of the circadian clock proteins, and you see sort of like this, it's like 24-hour cycle in expression of this protein. And very recently has come out a paper that shows that sort of like this circadian clock here might have an influence in basically ischemia reperfusion tolerance in the mouse. Just so there's this one slide here, you see basically mice that had their LAD ligated, occluded and then reopened, and then they were sacrificed, and the infarct size was measured. And you see here basically, so this is the light-dark cycle, and when sort of like it switches from light to dark, you see that the infarct size, all other things being equal, right? So the same territory of like ligation, the infarct size is significantly bigger. And when you knock this circadian clock out, which is here, this is a knockout mouse, where the circadian clock is knocked out just in the myocardium, right? So this has nothing to do with like what I told you before of like humoral influences of different blood pressure, heart rate, sympathetic tone. Just if you knock it out in the myocardium, you basically completely abolish this circadian response. And we were basically now interested sort of like, do we see sort of like this same pattern in the human population? We went to the level 1 database. We identified 1,000 patients with an ischemic time of less than 6 hours. We excluded all the patients that had not semi-zero flow at presentation, reason being because only if we really have semi-zero flow, we have an exact ischemic time, right? Or at least the end of the ischemic time is exactly defined. Whereas when we have semi 1, 2, or 3 flow, we don't really know what the ischemic time was, and that could have a big impact on the infarct time. We excluded all people with pre-infarction angina because obviously we know that this like reduces infarct time. We excluded people with prior MI because we don't really, because we measure our infarct size by the peak CK, and we have already a scar there that might significantly influence that. And I don't go through the rest in the sake of time. And so now if we plot the peak CK, which is our surrogate marker of infarct size, against the time of onset of ischemia, this points are basically the individual patient. And this, you see, this is a nonlinear regression to a sinusoidal curve, which is basically an accepted method of like analyzing circadian rhythm. And what it boils down to is if the amplitude of this curve basically is significantly different from 0, you have more or less proven that you have a circadian variation. And we see this one here is like highly significant. It's like P is less than 0.001. And it's actually, the difference is also quite big. It's a little bit like compressed because of this outlier here. But the trough value is like 80%, or the other way around. The peak value is like 80% lower than the trough value. So it's really a quite powerful factor that's potentially at work here. Now, of course, you might argue, and so we basically see like the sort of like this graph would argue that you have the highest damage or potential damage, or the highest susceptibility of myocardium to injury damage at around midnight. Now, the first question, of course, comes up, is that because at midnight people take longer to get to the hospital, have longer ischemic times. So we looked at that, and there's basically no difference between ischemic times throughout the day. So this certainly is not a confounding factor. Oh, I'm doing here, sorry. Not a confounding factor for this difference we have seen previously. The other thing that might potentially contribute is different areas of risk. I mean, if we have, 165 is a relatively large amount, but not huge. So if we have, like here at midnight, a few more proximal LAD lesions, it might very well skew our results. So we basically looked, what is the area of risk of all these people? And we looked in two ways. Number one, we looked at MRI. We had like 40 plus patients that did have MRI. And the area of risk is basically no different. We'll also look at approach scores. And I probably don't go into detail now what the approach score is, but basically an angiographic way of defining area at risk. And again, if you correct for that, the circadian variation is preserved. So again, arguing that sort of like this circadian rhythm is like, independent of ischemic timing, independent of area of risk, what we see here. Lastly, we thought if actually the ischemic injury is indeed worse during midnight, it would make sense that the heart function in itself is worse during that time and that's here. And to basically look for that, we looked at ejection fraction, plotted the ejection fraction. And sure enough, we see sort of like exactly the 12-hour shift in the curve of the sinusoidal curve. And again, it's a rather big difference of about like 8%, which I think is very significant and nicely sort of like correlates with, that the ejection fraction just opposite behaves to the myocardial injury or infarct side. What is one of the proposed mechanisms why the circadian clock sort of like influences the susceptibility of myocardial injury? Well, one is this sort of like this GSK3 beta that is part of the circadian clock protein that is like a circadian clock that is and in its dephosphorylated state can sort of facilitate the opening of the mPTP, which we know is a major factor in ischemia reperfusion injury. So basically, what our conclusions, number one, we showed that in humans, we have a circadian response to myocardial injury and LV function in the setting of the STEMI. And number two, the maximal injury occurs when infarction begins in the early morning hours, which basically fits very well with the mice data, where we have also see the maximum injury in the sleep-to-wake transition period. And one might consider basically that this has potential implications for future trials when you evaluate injury, ischemic reperfusion injury, that it becomes important sort of like at what time of day this injury occurred.
All right, a couple of questions while we're changing to Kevin.
Yes, it's basically an every mammalian cell that has a possible.
Well, how is the cardiac circadian clock and how do you know that?
Well, so I can answer really, for the mice data, I can answer that because the data I showed you was a knockout mouse that was specifically knocked out in the heart. So basically, all the circadian clocks in the other organ systems were. Can I answer? It's just an inference from the mouse data, right? I can't say from the human.
Any correlation with catecholamine levels?
Well, we know that the catecholamine levels show a circadian elevation, right?
Are they highest in the early morning hours?
Correct. Yes. And so that was basically, that is sort of like the idea, or has been the idea, while you have like more heart attacks.
The light driven change, but the light
Correct. Yes, you can. So when I showed you this graph of the circadian clock on the very top, it has sort of like an arrow that says like input, right? And so you can sort of like modify it.
So very good. Outstanding, Ron. And I think it's worthwhile now two things. Number one, how valuable the level 1 database has really become. We've now had over 35 manuscripts published using the level 1 and COOLET databases and aortic dissection databases. So it's become an incredibly valuable thing for us. I want to actually point out, if everyone looks at this list, so we talked about Mike earlier, but it's a very impressive American Heart Association for Jay. Jay is presenting one of the late-breaking trials, and actually, as you'll see on here, has 7 or 8 really excellent abstracts as well. And then, so the next we'll turn it over to Kevin. Kevin also is having a very impressive American Heart Association, if you look at all. And I think this is actually based both on our aortic dissection, as well as now he's been one of the key people for IRAD.
Yeah, thanks, Tim. This one's actually from the IRAD group. As you know, I have a long-standing interest in intramural hematoma. But the IRAD registry, which we've been part of now since 2005, does offer us the ability to look at questions in detail, like in our recent circulation paper as well. So if anybody has any thing that they'd like to look at, please talk to me. And you know, we have 3,000 patients. We can certainly answer the questions. I apologize. First of all, the slides are a little rough. I still have 2 weeks before this is an oral presentation. And so we need to put some logos and maybe a few more charts and images. I might ask for your help, Rob and Terry, on that. But aortic intramural hematoma represents an important subgroup of aortic dissection. It's characterized by crescentic thickening of the aortic wall with absence of the typical intimal flap or the entry point. There is controversy regarding the optimal initial management of this condition. The earliest studies suggested an adverse risk similar to that of conventional aortic dissection. However, more recent studies coming out of Asia primarily have suggested that this condition could be treated medically. And thus there is some confusion in the literature. And this does show a case here with the non-contrast CT, here again showing that crescentic thickening of the aortic wall, and then also on the right on the non-contrast CT. Oops, it's like the world map didn't show up there, but this is the group of IRAD centers. There's now 24 centers in 12 different countries around the world, but you will notice that as far as the Asian centers, there's only one center. It's a relatively low-volume center. However, this large database does allow us the opportunity to answer questions such as that with intramural hematoma. So the objective of this study was to understand the differences in presentation, management, and outcome between patients with typical or classic aortic dissection and those with intramural hematoma. So our data base included all patients presenting with acute dissection in the IRAD registry since its inception in 1996 through 2011. Intramural hematoma was defined on the initial imaging test, and these patients were then contrasted with typical aortic dissection with regards to demographics, presentation, symptoms, management, survival. Intramural hematoma was found in 182, or 6% of the 2,908 total cases. Interestingly, incidence ranged from 0 to 22% between different sites. 72 of the patients were type A, representing 4% of the type A group, and 110 type Bs, representing 11% of the type Bs. Typically, aortic dissection is characterized by a majority of type A dissections. In intramural hematomas, most of them are actually type Bs. So what we see here is the demographics and history for type As and type Bs, and then split between intramural hematoma and classic dissection. As you can see here, patients were older that had intramural hematoma of the ascending aorta, aorta, but younger than type Bs. Although aortic dissection is primarily a disease of males, nearly half of the patients with ascending intramural hematoma were females. There was a minority of non-white patients with intramural hematoma, and more type A's had hypertension. Just like classic dissection, patients with intramural hematoma present with typical symptoms, abrupt onset of severe chest or back pain. However, they're less likely to present with aortic regurgitation or with pulse deficits, specifically when the ascending aorta is involved. As far as the testing, the EKG is more likely to be normal in intramural hematoma than with classic dissection. These patients with intramural hematoma tend to have more imaging tests performed. However, the time from the onset of symptoms to diagnosis is actually fairly similar. Periaortic hematoma is far more prevalent with intramural hematoma, both A and B, than it is with classic dissection. And nearly 60% of patients with type A intramural hematoma have pericardial effusions, as shown here, which is more common than with classic dissection. So this slide shows us how these patients are managed. 22% of these in our database are managed medically, which is higher than with the classic dissections for the type A group. Both the surgical and endovascular treatment was also less likely for the type Bs. However, if the patients did get an intervention, the time from surgery to presentation was actually fairly similar. So this slide shows the outcomes. And as you can see here, the mortality in the hospital was identical for patients with a classic dissection versus intramural hematoma of the ascending aorta. As far as medical management, again, fairly similar mortality, nearly 40%. Actually, it is 40% die. I'm not fully shown here, but other complications such as stroke, myocardial ischemia, et cetera, was similar between the two groups. And the one-year mortality is also fairly similar. So in conclusion, intramural hematoma represents 1 in 20 acute aortic presentations in the IRAD registry. Patients have similar symptoms, but are less likely to have pulse deficits or aortic insufficiency, but they're more likely to have pericardial effusions and periaortic hematoma. Patients were more likely to be treated medically, but they have an identical hospital mortality, and those treated medically have a 40% inpatient mortality. So I think these data would support an approach to intramural hematoma similar to that of classic aortic dissection. Questions? Okay.
Is there any issue with imaging? It's fairly straightforward to make this diagnosis.
Well, I think that's an important question, because you can see that, you know, one of the things that we've been interested in is looking at the incidence across the world, and it's usually far more common in like an Asian population. Many of those series say that the incidence of this is 20–25%, whereas other centers in our you know, these are places with some experience with aortic dissection, they never call it. So I was expecting a little bit longer times to the establish, you know, these patients get more tests, but I think it does come down to the experience of the reader, familiarity with the terminology, and I mean, we know that, you know, some of these get called second aortic wall or heavy atherosclerosis, especially if it involves the ascending or something like that. But I think if, you know, it's the same test, you know, basically CT or CT is probably the best. MRI and TE are also very good. you're not going to see it on aortic sound. Yeah, it's identical. I have all that data, which we'll put in the paper, but it's identical symptoms.
All right, great. And the last, we're actually going to have Sue Stendelbach is going to also present, and Sue has actually done really great work, is working actually on the program committee for American Heart Association next year. So from a nursing standpoint, it's really great because it gives us contact with AHA. And has an NIH grant?
We're submitting on this.
And I'll say for everyone who wasn't here, take a look at the list of all the presentations at TCT and American Heart Association. You'll see, which are right outside the door. You'll see it's quite impressive.
What our group looked at was the effects of variation in temperature management on CPC scores in patients who received therapeutic hypothermia post-cardiac arrest. And just to give you a little context, there are almost 500,000 in and out of hospital cardiac arrests every year in the United States. And previous survival rates were as low as 2%. They are now up to 56%. And cardiac arrest with therapeutic hypothermia is recognized as a standard of care both by the American Heart Association and ILCOR. So what we were interested in is looking at CPC scores. Most scores are collapsed 1 and 2 for good outcomes and 3, 4, and 5 as poor outcomes. However, what we were interested in is how do you differentiate between 1 and 2? Because when patients are discharged to home, this has an impact on them. For CPC 1 is the patient's conscious, alert, able to work, and might have mild or neurological or psychological deficit. In CPC 2, the patient may have to work in a sheltered environment. So when you're planning discharge care, when can they return to work, when they can drive, these are significant. So the aim of the study was to identify predictors of neurological outcomes in patients who receive therapeutic hypothermia post-cardiac arrest. The time period of the data collection was February 2006 to July 2010. It was approved by the IRB. It was a retrospective, non-experimental observational design. The sample were only out-of-hospital cardiac arrest patients treated with therapeutic hypothermia, non-traumatic cardiac arrest, return of spontaneous circulation within 60 minutes, and the patient was unconscious, i.e. did not follow commands. The data collection methods, we used the INCAR database. All data were originally documented in the EMR and healthcare records in the course of standard care. We used standardized definitions for patient characteristics, care processes, and outcomes, and all data were input by a certified nurse researcher. The 3 outcomes, again, that we looked at were the good, CPC 1, and moderate, CPC 2, and then poor, CP 3 to 5. We examined these outcomes at 3 time points: transfer from the ICU, hospital discharge, and at least 1 month post-discharge follow-up. And if the patient died while in the ICU, a 5 was assigned for the CP score, also at hospital discharge and follow-up. So our predictors of interest were time of initiation of therapeutic hypothermia, time to target temperature, duration of therapeutic hypothermia, and the covariates that we examined included were gender, age, pre-arrest health conditions, time to return of spontaneous circulation, initial rhythm, length of stay in the ICU, and the hospital length of stay. Our analysis, descriptive statistics to use characteristics of patients, the time intervals, and the neural outcomes. We used a regression model to estimate the odds of having a poor outcome to a good outcome, and we used both adjusted and non-adjusted. So our results demonstrated that our average age was 63.6 years, predominantly male population. Rhythm at arrival to the hospital, VTAC was the predominant rhythm, 72.2, PEA 12.8, asystole 11.1, and unknown 3.5. The time intervals, arrest to ROS was in minutes, 23.9 minutes. Arrest to therapeutic hypothermia treatment was 94.4 minutes. Arrest at target temperature, 309 minutes. And target temperature was maintained in hours, 23.1 hours. The time interval, days from arrest to hospital discharge, 9.1. Length of ICU stay, 7.1 days. Length of post-ICU hospital stay, 5.0 days. And our follow-up time was in months, 7.5 months. So our first question of looking at hospital or transfer from ICU, the time from arrest, and we looked at it in 5-minute increments, we found that there was a 6% greater odds of having a poor outcome than a good outcome for every 5 minutes delay. Also, in looking at hospital discharge, we also found that there was a 6% greater odds of having a worse outcome than a good outcome, again, in 5-minute increments. Time from hospital at follow-up period, we found that there was an 8% greater odds of having a poor outcome to a good outcome and a 5% greater odds of having a moderate outcome to a good outcome for every 5-minute delay. And again, these were adjusted for age, gender, initial rhythm, and hospital length of stay. Finally, we also examined amount of time to target temperature in 30-minute increments. The only time it turned significant was on follow-up discharge, and we found that there was a 17% greater odds of having a worse outcome than a good outcome for 30-minute delays in therapeutic hypothermia reaching target temperature. So for every 5-minute delay in initiating therapeutic hypothermia at transfer from the ICU, there's a 6% greater odds of having a poor outcome. At hospital discharge, there's also a 6% greater odds of having a poor outcome. At post-hospital discharge, there's an 8% greater odds of having a poor outcome than a good outcome for delay in initiating therapeutic hypothermia. Finally, for every 30-minute delay in time to target temperature, there's a 17% greater odds of a good versus poor outcome. In patients undergoing therapeutic hypothermia post-cardiac arrest, delay initiation of therapeutic hypothermia and reaching target temperature differentiated between a poor and good outcome. Future research did look at randomized trials assessing the current recommended guidelines for therapeutic hypothermia. Limitations include this is a retrospective study. Imprecision of the estimated times to therapeutic hypothermia. We got this from EMR records, different records out there, and it was just an estimate. And although depth of target temperature was a variable of interest, what we found was almost all patients were at 33 degrees Celsius, so we couldn't really analyze that. And another limitation is the sample is primarily men. And thank you.
Questions, comments? All right. Great. Thanks everybody for coming this morning. And again, we're going to present the late-breaking trials pathway. All right.